Hello, and welcome to the field of geriatric emergency medicine, where the older your patient is, the more likely they are to be hiding a deadly diagnosis. I have no relationship with a commercial interest to disclose. I am Dr. Nicole Cimino Fiallos. I am a practicing emergency medicine physician in Hagerstown, Maryland. I work at Meredith Medical Center. I developed an interest in the care of older adults back in residency, and since then I've worked with the American College of Emergency Physicians Geriatric ED Accreditation Program. I have started 2 geriatric emergency departments, and I publish and lecture pretty extensively in the field of geriatric emergency medicine, specifically with elder abuse and neglect. Today we're going to review 6 cases that relate to high-risk parts of geriatric emergency medicine. We're going to address some scenarios specific to older adults and hopefully teach you some high-yield pearls that you can use in your next shift to take better care of our geriatric patients. We don't talk about COVID. I know you're singing the actual song in your head right now. If you have a 6-year-old and a 3-year-old like me, this song plays in my house constantly. But yeah, I'm sick of talking about COVID. I know you are too. We're all tired of it. But we would be remiss if we didn't talk about how this disease is biased towards older adults. So we're going to see a patient here. It's a 79-year-old female. She has a past medical history of hypertension, hyperlipidemia, and diabetes. That's how we know she's from Hagerstown, Maryland, because everyone has those diseases in our ER, it feels like. This patient's coming in for 2 days of anosmia, cough, and fever. She reports that in 2021, she got 2 COVID-19 vaccines, but she hasn't gotten her booster yet, just didn't get around to it. What prompted her to come in today is that she started to feel short of breath when going up the stairs in her house, and so she wanted to come in and get checked out. She's having a little trouble getting her activities of daily living done because she's feeling so short of breath. So this sounds pretty classic for COVID-19, so we're going to swab this patient, and her rapid test is positive. We're going to get her admitted to the hospital because on an ambulatory pulse ox, the patient became hypoxic. So obviously, we have to be continuing to think about COVID-19 in our emergency departments. Unfortunately, it does seem to target our older adults. And we know that the older our patients are, the more severe their disease. Older adults are more likely to require hospitalization, they're more likely to develop pulmonary failure, and they're more likely to need invasive or non-invasive ventilation. In 2020, our older adults contracted approximately 15% of all cases of COVID-19, but unfortunately, they accounted for more than 80% of the deaths. Older adults were 80 times more likely to die in 2020 and 2021 from COVID-19. Of all the deaths, 81% were in patients over the age of 65, whereas only 19% were in patients less than 65. As I mentioned, these patients are more likely to have respiratory failure and complications of the disease process. So we know what symptoms we see in younger patients with COVID-19. They're similar in older adults. Older adults will develop those symptoms of fever, cough, body aches, lethargy. We're more likely to see more severe symptoms like dyspnea, tachypnea, hypoxia. And what's different in older adults is they're more likely to experience delirium in COVID-19. And that may be their only symptom. So whereas younger adults will have more of the classic features of COVID-19, an older adult could just come in with not acting right. In Hagerstown, we call that talking out of their head. They're a little more confused. You can think about, if someone's having a waxing and waning change in their cognition, that could be delirium, and that could be a sign of COVID-19. So we actually recommend if you have an older adult coming in with delirium as their only symptom or diagnosis, screening and looking for COVID-19. Unfortunately, if your older adult does have delirium and COVID-19, they are more likely to have complications, prolonged hospitalizations, and even death in this disease process. There is some good news now that we have vaccines for COVID-19. Risk of severe illness from COVID-19 increases after 6 months of the vaccination, but for the first 6 months, you're pretty well protected. A booster does protect against hospitalization, decreases your mortality by about 90%. And we were glad to see that the booster has shown good efficacy in the Omicron variant stage of this pandemic. And hopefully that effect continues as we see future variants. I was happy to know as I was preparing for this talk, that more than 90% of our older adults are now vaccinated against COVID. In the current political setting, I didn't expect the number to be that high, but I am happy to report that most older adults have at least gotten their initial 2-shot vaccination. We do have some treatments now for adults that are diagnosed with COVID-19, which is welcome news after the past 2 years that we've been in. A lot of us have access to monoclonal antibody therapies in our hospital systems. These are IV infusions, and they have shown that they decrease hospitalization and death in outpatients with mild to moderate COVID-19. The challenge with these monoclonal antibody therapies is that depending on your local variant, that decides which monoclonal antibody will be effective. And so we saw this in my hospital system when we switched from having mostly Delta variant to having mostly Omicron variant. Our monoclonal antibody therapies weren't as effective. There are some new drugs on the market. They keep naming them with more complicated names that I have to stumble over them during my lecture. But if you have heard of the molnupiravir, it's a new oral medication that came out. It's been shown to have a 30% decrease in hospitalization and death if given within 3 days of symptom onset. The challenge with this medication is that it's not great for people with mild to moderate chronic kidney disease or severe kidney disease, and it's not great with people that have hepatic disease. It also was studied mostly in the setting of the Delta variant, because as it was being developed, that's the variant that we had. And so the efficacy in the Omicron variant is to be determined. Another new medication that came out was the nirmatrelvir and ritonavir. It's a combination drug. This is another oral medication that shows a pretty substantial decrease in hospitalization, 88%, if given within 5 days of symptom onset. The trouble with this medication is that it has a lot of medication interactions, and most of our older adults are on at least a few medications for their chronic conditions. And so you have to be cautious with this medication because it will interact with anti-epileptics, antiarrhythmics, some anticoagulants, and so we need to do a very thorough medication review prior to prescribing this medication. The good news with this medication is that you can use it in renal disease, mild to moderate, and liver disease, mild to moderate. Remdesivir had its 15 minutes of fame earlier in the pandemic. There were some initial studies that showed some benefit to giving this medication to patients with moderate to severe COVID-19 that were hospitalized. It's an IV medication. And as I said, initially there was some promise that this was going to help our patients with COVID-19 diagnosis, but a recent review showed that it may not actually have any effect. And the trouble with this medication is that it may prolong your hospital stay and keep patients in the hospital longer because it's an IV infusion and they have to be on it for 5 days. Steroids were really big in the beginning of the pandemic. We were giving steroids to seemingly everyone with COVID-19 to try to get them feeling better. We didn't have a lot of options, and so that's what we used. It's had a proven benefit for steroids in patients with hypoxia or patients that are requiring respiratory support, but in patients who are not hypoxic, not requiring respiratory support, steroids probably don't help. They may make them worse. And our older patients specifically don't tolerate steroids well. I saw a patient a few days ago who was diagnosed with COVID-19 as an outpatient. He's 75, he has diabetes, and he was given a course of steroids to try to make him feel better because he was feeling pretty tired and short of breath. But the patient ended up coming into the emergency department because his blood sugar was over 600 and he was starting to get a little bit confused. So we have to be judicious in our steroid use, and we have to recognize that they're not completely benign medications, and we want to use them for the proper indication, which is patients with requiring respiratory support or having hypoxia. High flow oxygen is one other thing that has come out of the treatment of COVID-19 in older adults. It has a number needed to treat of 6 to avoid 1 intubation in geriatric patients, which is great. Anything we can do to try to keep these patients off a ventilator is good. But high flow oxygen has not specifically been studied in older adults. I think we can assume it's good for them. I've seen it work great wonders with patients coming in with mild to moderate hypoxia and needing respiratory support in the emergency department. So overall, what I want you to take away from this case is that COVID-19 continues to be a threat to our older adults. We should continue to advise them to get vaccinated if they're not, and we should encourage them to get booster shots to try to decrease their morbidity and mortality if they are infected. Our next case is reminiscent of those commercials from the 90s when I was a kid for the Life Alert button. I tried to get my grandmother a Life Alert button. She never wore it. It sat on her dresser, so I tried to follow those commercials. But this is a 90-year-old female who comes to the emergency department. She lives alone. She was walking around her house. She tripped on a rug. She fell. She landed on her right hip. She couldn't get up. She pushed her Life Alert button and called EMS. Paramedics get there. Her right leg is shortened. It's externally rotated. She can't stand. And they call the box, the ambulance box in my ER, and they say, we've got a 90-year-old female with a shortened and externally rotated leg. And I'm like, great, because this is an easy one. This is not one of those complicated cases of someone who has a liver transplant and they come in for not feeling well, then I've got to do this $1 million workup. This is an easy one. So what does this patient have? Well, I assume she's going to have a hip fracture. Hip fractures are extremely common in the United States. There's more than 300,000 per year. 1 in 3 women and 1 in 12 men will experience a hip fracture in their lifetime. And unfortunately, 30% of older adults that experience a hip fracture will die within the first year after their fracture. And that's not necessarily because of the fracture itself. So some of these patients, unfortunately, will die because of complications from the fracture. They may have difficult surgical courses. They may develop post-operative complications like a pneumonia, urinary tract infection, get septic, all those things. But not all patients will experience the post-operative complications. Some patients will experience complications of frailty syndrome. So as patients age, they develop this constellation of symptoms related to frailty, where they're just not as mobile as they used to be. They become deconditioned, and those patients will have recurrent falls and may pass away in the next year because of that. Recurrent falls on their own are a risk factor for morbidity and mortality. If you've fallen once, chances are you will fall again, and maybe that time you'll hit your head or suffer some more serious injury. So our patient comes in, she's had this fall, her right leg, she comes in, she can't straighten it out, it's short, it's externally rotated, and so what test do we want to get? Well, obviously we're going to get an x-ray. So we get this x-ray, and it's not a slam dunk. We thought it was going to be a slam dunk hip fracture. I already had the orthopedist on my text messages ready to get him on board to help take care of this patient. And I get this x-ray, and there's no definite fracture. I don't think there's a fracture. Would I bet my paycheck on it? I don't know. We see some severe osteoarthritis. We see some sclerosis of the femoral neck. Maybe this is an occult fracture. It's hard to say. I don't know. So I say, well, let's see if the patient can walk on it. We see no definite fracture. Let's try to get her up and moving. Maybe it's just a bruise from her fall. And this patient can't get up. She can't bear weight. She can't walk around. So what next? Now what are we going to do? That was the easy part. We thought we were done. So obviously this patient can't go home. She can't walk. So we need to do a different test. So do we send her to the donut of truth? I have a CT scan in my emergency department. I'm thinking, I know that x-rays have a 40% miss rate for occult fracture. And I know that of the fractures that are missed on x-ray, most of them do require surgery when they are ultimately diagnosed. So I don't want to miss a fracture. I don't want to delay this patient's time to surgery. So I'm going to run her through the CAT scanner and see if there's an occult fracture. What people don't realize is that although CT is good and has good sensitivity for hip fractures, it's not perfect, and it will still miss fractures. So MRI is still the gold standard for diagnosing a hip fracture in an older adult that you suspect an occult fracture. MRI is hard to get. I could probably get an MRI pretty quickly in my emergency department between the hours of 9 to 5, but otherwise it's hard to get an MRI. So what I recommend is starting with a CAT scan and seeing if there's any fracture. If your CAT scan is negative, but your patient still cannot walk, they could still have a fracture. And of the fractures that are missed on CAT scan, more than half of those often require surgery when they are ultimately diagnosed on MRI. So I recommend starting with an x-ray, and then if that x-ray is negative, but you still suspect a fracture, try to get the MRI if you can. If you can't, start with CT. But once that CT comes back, if it's negative, don't discharge that patient home. That patient should move on to the next test, which is MRI. So our take-home pearl for this case is that CT does not have high enough sensitivity to completely rule out occult hip fractures, and patients in whom we have suspicion for an occult hip fracture should go to MRI for further workup, because CT does not have high enough sensitivity to rule out these types of breaks. Obviously, this is still controversial. More data is coming out all the time, but that's the stance that I would take. Our next case is an 86-year-old female who comes into the emergency department with chest pain for 4 hours. The chest pain started while she was going up the stairs. She reports that it was in the center of her chest. It was a heavy pressure. She felt like she couldn't catch her breath. She broke out into a sweat. The pain started radiating to her jaw and her left arm. And she has a past medical history of 2 prior cardiac stents, a pacemaker, hypertension, and hyperlipidemia. So this sounds like a pretty good story for acute coronary syndrome. And I am really worried about this patient. So the first test I'm going to get is an EKG. So we get this EKG, and there's some scary stuff on here. Patient has ST elevations in V1 through V3. She has some ST depressions in 1 and AVL. But the patient has an atrial and ventricular pacemaker. So that's going to produce this similar to a left bundle branch block appearance. And I'm just envisioning calling my cardiologist and saying, hey, I've got this lady here. She has a really scary story for an acute coronary syndrome, this terrible crushing chest pain, sweats, radiation of the pain, all the things that we look for. And I'm really worried that she may have an occlusive myocardial infarction. And I know that I'm going to send this to my cardiologist, and he's going to look at it and say, this patient has a pacemaker. We can't tell anything from this EKG. So why does it matter if we diagnose these occlusive myocardial infarctions in patients with paced rhythms? Well, it's hard to estimate how many people in the United States have pacemakers, but various sources suggest that anywhere between 500,000 and 3 million Americans have a pacemaker in place. And while that is not unique to older adults, about 0.4 in 1,000 people under the age of 64 have pacemakers, and about 25 to 70 in 1,000 patients over age 65 have a pacemaker. Average age for a pacemaker placement is around 75 years old, and we know that these patients typically have concomitant coronary syndrome and risk factors for acute coronary syndrome. So patients that come to the emergency department with pacemakers in place could be having occlusive myocardial infarctions, and it's really important that we are using the EKG to help diagnose these quickly. Studies have shown that people with pacemakers and occlusive myocardial infarctions are less likely to receive emergency reperfusion therapy. They're less likely to go to the cath lab emergently, if at all, and they're more likely to die from these disease processes because they're not getting the right treatment. So what can we do to try to mitigate this problem? Well, we can treat these EKGs like we treat left bundle branch block EKGs. We can use the modified Sgarbossa criteria to assess if this person is having an occlusive myocardial infarction or not by EKG. So what we're looking for is concordant ST segment elevation greater than 1 millimeter in any lead, concordant ST segment depression greater than 1 millimeter in any of the leads V1 through V6, and proportionally excessive discordant ST elevation greater than one lead anywhere greater than or equal to 1 millimeter of ST elevation as defined by greater than or equal to 25% of the depth of the preceding S wave. So I have to look these up every single time I'm looking at an EKG with a left bundle branch block or with a pacemaker, but it's worth doing because I can say to my cardiologist, this is validated data. We need to take this EKG seriously. This person has a great story for acute coronary syndrome, and I think she needs to go to the cath lab so that we can get her feeling better. And so my pearl here is that you're going to have to go to bat for your patients with your cardiologist. I had to go to bat with my cardiologist for this patient's EKG that I showed you earlier. She ended up having an occlusive myocardial infarction. She ended up going into flash pulmonary edema, having congestive heart failure. This patient got really sick really quickly. And so it's important that we're getting these patients to the cath lab as soon as possible, getting them the treatment that they need. And it's important to remind our cardiologists that EKGs with ventricularly paced rhythms can be interpreted for occlusive myocardial infarction using the modified Sgarbossa criteria. So our next patient is an 80-year-old female who comes into the emergency department with a Baltimore special. I trained at the University of Maryland in Baltimore, and whenever someone came in for passing out, it was called a DFO, a done fell out, and I've carried that with me through my training as I see patients for syncope. So this is an 80-year-old female, past medical history of hypertension. She has been having dyspnea while walking around and doing her activities of daily living for months, and today she was walking around the library just looking for a book, and she passed out. Luckily, she was with a friend. Her friend caught her. She did not hit her head. And so we're seeing this patient in the emergency department. She's sitting there. She's resting comfortably, one of these nice gray-haired old ladies. She's awake. She's alert. She's oriented. She calls me dear. And when I'm listening to her heart, she has a harsh, late-peaking systolic murmur. And so when we're thinking about someone who's passed out, the list for the differential diagnosis just goes on and on and on. It's like a CVS receipt. You have dysrhythmias, cardiac valvular disease. It could be cardiac ischemia. It could be a blood clot. It could be a subarachnoid hemorrhage. It could be the big red, the AAA. It could be a medication side effect. It could have been a vasovagal event. It could be carotid sinus sensitivity. It could be situational. Did they just pee? Did they go to the bathroom? Were they coughing? Were they laughing too hard? Are they orthostatic? Is it orthostatic hypotension? So this list is not even this doesn't even include everything we have to think about, but there are so many things we need to think about. Some are benign, some are life-threatening, and so we have to look for high-risk features and clues that might lead us to the diagnosis in a case like this. So what are these high-risk features? What are things that we need to be on the lookout for in our older adults who are coming in after passing out, after having a syncopal episode? So we need to look for, is their EKG abnormal? Is their EKG abnormal? Are they having signs of ischemia? Do they have a history of heart disease? Any history of dysrhythmias? Prior to passing out, did they have palpitations? Was their heart racing, or did it feel like it was skipping a beat? Were they exerting themselves when they had this episode of syncope? Or were they just laying in bed and they lost consciousness? Was there a prodrome? There's a difference between I was outside weed whacking, as my 85-year-old patient I saw last week was telling me. I was outside weed whacking and I didn't drink any water and it was 90 degrees and I felt lightheaded. That's really different than somebody who was just walking around and just dropped. So we need to talk about predisposing events. Did something else happen? Anything that would give us a clue as to why this person lost consciousness. And we did get a clue for this patient that we're seeing because on her exam she had a new murmur. So that might make us think of something like aortic stenosis. So this particular case, I'll be truthful, I borrowed from a friend of mine. She saw this patient a few weeks ago in Hagerstown at Meredith. And it was a really interesting case because prior to passing out in the library, the patient had been hospitalized a week ago for a presumed pneumonia. And the patient reported that she had come into the ER having this shortness of breath, this not feeling well, and her x-ray had shown some pulmonary edema versus pneumonia with a little pleural effusion. And so she was admitted for the diagnosis of pneumonia, and that diagnosis didn't really fit. And she got some antibiotics, she was discharged home, and then she was coming back with the syncopal episode. And as my colleague, my friend, interviewed her further, she got more of the story of what had been going on over the past few months. And this patient had a classic story for aortic stenosis. This patient reported she'd used to walk 2 miles per day with no problem. And now when she would try to walk to her mailbox, she got very short of breath. She had to take a break. She felt very tired. She'd been having some intermittent chest pain and even some intermittent palpitations, presumably some new atrial fibrillation. This patient was admitted to the hospital after this syncopal event, and she had an echocardiogram, which showed the expected left ventricular hypertrophy and increased flow velocity through the aortic valve on the echocardiogram. So most of these patients will require aortic valve replacement at some point. And aortic stenosis is really common as we age. You get that just calcification of the valve, and you get that poor left ventricular outflow leading to these symptoms. So our take-home pearl for this case is that aortic stenosis can be kind of tricky in its presentation. It can be a little bit difficult to diagnose if you really don't dig into the details of what symptoms the patient has been experiencing. They may report decreased exercise tolerance, and ultimately they may have a syncopal event. But the other important thing to learn from this case is that syncope in an older adult can be very dangerous. There can be a hidden life-threatening diagnosis there, and it's really important to get that detailed history to figure out what caused this older person to pass out. Our next case is an 85-year-old female who's coming into the emergency department after a fall. The nurse comes to you, this patient's in the waiting room, and it's your charge nurse, and she says, "Oh my gosh, Mrs. Jones is here again. She's been here 3 times in the past 3 months. I see her more than I see my mother. I can't believe she's back again." And she fell. She keeps falling. So the patient reports that she fell today. She's got bruising to her face. She's got a cut on her left ear. Her son is bringing her in. He's her caregiver. He always brings her in. And he notes that she has a past medical history of hypertension, incontinence, and frequent falls. So we see this case all the time. Unfortunately, older adults are very prone to falls. So this case really is pretty common. But as you were reading through that case on the last slide, and as I was talking about it, did you notice any red flags? Anything that made you think, something's not right here. Maybe we need to think about elder abuse. So I hope so, because this is my niche. This is my what I like to talk about, because I like to make people more aware of this life-threatening, commonly missed diagnosis. And one of the side effects of COVID-19 that people don't realize is we suspect the incidence of elder abuse has really increased over the past year. Caregivers have been isolated. They haven't had some of the support that they usually got from the community. Older adults are isolated, which limits the ability of them to report when people aren't treating them well. And so we really need to be on the lookout for elder abuse in the emergency department. There are some red flags in the story that I told you about this patient. So anytime someone has an injury to the ear, neck, left side of the face, or forearm, we should think about elder abuse. Child abuse literature is much further ahead than elder abuse literature in this sense, because there are verified injury patterns in child abuse that have been established for years, taught to medical students, taught to residents. But there are also established injury patterns for older adults that are experiencing abuse. So most abusers with physical abuse are right-handed, and so most older adults that are punched or hit will have injuries to the left side of their face. Injuries to ears are extremely unlikely in an accidental fall. Similarly with the neck, you just don't typically injure those as you fall to the ground accidentally. Forearms are at risk for injury as older adults use their forearms to defend or cover their face to protect from physical abuse. Other things that should clue us into the possibility of abuse, look for frequent emergency department visits. So patients that are well established with their primary care doctor and well taken care of don't typically have to come to the ER that often. So if someone's coming in all the time, especially for traumatic injuries, you want to think about, could this be an abuse or neglect situation? Patients with poor medication compliance, that could also be a red flag for abuse. So you have a patient that's coming in, it's their 3rd visit for blood sugars over 500, and you say, "Mrs. Jones, I don't understand why your blood sugar is so uncontrolled. You're on the right medications. You say you're doing all the right things. What's going on?" Well, maybe their caregiver is not giving them their medications as scheduled. Maybe they haven't filled the prescriptions. Maybe they're not following up with their primary care doctor to get the refills that they need. So that can be a red flag. Incontinence puts patients at risk for caregiver abuse or neglect because it increases caregiver burden as well as cognitive decline. So patients may come in with soiled clothing, not looking like they're being washed or well taken care of. And then a final red flag that I just wanted to point out is any genital injuries or sexually transmitted infections should always raise your suspicion for elder abuse, especially in patients with cognitive issues, dementia. And so you really do need to dig further into why that patient has this particular injury or infection when they come to the emergency department. I recommend using a screening tool to help you diagnose or look for elder abuse in older adults. The benefit of a screening process, screening tools are not great in this field. They have had troubles with getting validation of sensitivity and specificity, but the reason I like a screening tool is because it's a standardized process that helps you remember to look for this frequently missed diagnosis that can be life-threatening or debilitating. So the screening tool that I like is the Elder Abuse Suspicion Index. The acronym is EASY. It's easy to use. You could do this test in about 5 minutes. And it looks at multiple abuse categories. So it looks for financial abuse. It asks patients if they've relied on someone to sign their paper, sign their checking statements, those types of things. Has anyone asked you to sign a paper you didn't want to sign in the past 6 months? It looks for sexual abuse. Have you been touched in a way you didn't want to be touched? It looks for neglect. Do you rely on someone to help you bathe, dress, shop, bank, get your meals? Has anyone prevented you from getting food, clothes, medication, these types of things? It also specifically asks, have you been punched, hit, looking for physical abuse. So I like that it spreads out along several different categories. There's also a question in the EASI that asks the doctor or the assessor, whoever that may be, whichever clinician is performing the screening test, did you notice poor eye contact? Did this patient seem afraid of the caregiver they were with? Did you notice anything that was suspicious for elder abuse or neglect? And that's incorporated into the screening. This tool has been validated in the outpatient setting, and it's highly specific for elder abuse. So if it's negative, it's not as sensitive as we would like. But if one of the screening questions is positive, that is very concerning for elder abuse or neglect. So if you diagnose a case that you suspect elder abuse, what do you need to do? So clinicians are all mandatory reporters for elder abuse in all 50 states. So if you suspect it, you need to call Adult Protective Services and file a report. We are not investigators. We are not responsible for investigating abuse. Our job is just to suspect it and pass it on to the investigative agency, which is Adult Protective Services, so that they can do an investigation. Now, we can help them with their investigation by doing a good job with our documentation of these cases. So if you have a patient with injuries, it's important to document where they were, what did they look like, maybe measure them, provide photo documentation in the medical record if possible. And that also helps our colleagues that are trying to take care of these patients as well. So it's helpful for a patient's primary care doctor if we've documented injuries well, they can follow the course of the injury, make sure things are healing appropriately. We should admit patients if they're unsafe. We should never be sending someone home to an abusive environment if it's unsafe. And we should try to if we are going to discharge someone home, we should try to develop a safety plan for them to keep them safe. So we need to ask them, who will you call if you feel unwell or in danger? Can someone check on you? Maybe your neighbor, your pastor, your friend. Do you know how to call 911? Do you have access to a phone? And then we want to build a team to help us take care of this patient. We can't take care of this patient on our own from the emergency department, so we want to engage the patient's primary care physician. We want to engage a social worker, maybe a case manager to follow up and help make sure this patient's getting their medicine, has access to food, has maybe home health coming in to help take care of them, and really making as safe of an environment as we can for these patients. We don't want to send patients back to a physically abusive environment, but if someone comes in for neglect, maybe their caregiver is overwhelmed and trying to work and take care of this older adult, and they just need help. So offering additional services, resources may be a good way to get this patient feeling better and to give their caregiver a little bit of respite. So what I would like you to take away from this case is that 1 in 10 older adults will experience maltreatment in their life. Elder abuse puts them at risk for death and also puts them at risk for high morbidity, more hospitalizations, more ER visits, and just worse health overall. So please keep elder abuse on your mind. It has increased during COVID. We need to be more vigilant than ever, and remember that we do miss this frequently, and we need to be constantly screening and looking for it. Our final case is an 86-year-old male with a past medical history of end-stage renal disease who comes to the emergency department complaining of a rash. These are the worst, right? You don't know if you're going to know what it is. You walk into the room dreading, what kind of rash is this going to be? Where am I going to find a dermatologist? It's like finding a unicorn in the emergency department, or at least that's what runs through my head when I need to go see someone with a rash. That's one of my least favorite complaints, but here we go. We're going to go see this patient. We walk in, and he says, it's right here on the left side of my chest, and you move his gown up, and you look, and you're like, oh, thank God, I know what this rash is. This rash is shingles. It was easy. Perfect. He's got those vesicles. It's red. It's in a dermatome. We've got this. And so we're feeling good. And we prescribe this patient valaciclovir, 1,000 milligrams orally, TID for 7 days. This patient's going to get better, and we can go to the next patient. So this patient got discharged home. He comes back 3 days later. He's hallucinating, he's agitated, he's confused, and the rash is better, so that's good. But he is climbing out of the bed, climbing over the walls, just really, really agitated. His wife is upset and worried. So this patient is experiencing delirium. Delirium is an acute decline in cognitive function. It's very different from dementia, although they're frequently confused. Dementia is a slow cognitive decline over a long period of time, whereas delirium is sudden. It happens in, a day, a couple of days. They're fine, and then they're very confused. They may be hallucinating, they may be agitated, they may be talking out of their head, and then sometimes they may be coherent. So it really goes in and out. We do need to remember that delirium can be hyperactive. That's the delirium we think of when we hear about these kinds of cases, and that's how this patient was, climbing out of the bed, confused, seeing things, very, very agitated. But there is also the other side of delirium, which is hypoactive delirium. So someone may just be more lethargic, more out of it, not really eating, and that could be delirium too. The good thing about delirium is that usually it's reversible if you can identify the cause, but delirium can be life-threatening, and so it's really important that we try to figure out why patients are delirious, treat it, reverse it, and get them feeling better. So with this person, what we didn't do when we treated him for his shingles rash is we didn't consult the Beers list. The Beers list is a list of medications that's maintained by the American Geriatric Society, and it's a list of medications that should be used with caution in older adults. It also lists drug-to-drug interactions that should be avoided in older adults, and it lists medications that require renal dosing for adults with chronic kidney disease. And if we had consulted this list, we might have realized that a lot of common medications that we use in the emergency department are on the Beers list requiring renal adjustment. So valacyclovir is a medication that we use to treat shingles as well as acyclovir, but in older adults with chronic kidney disease, we need to adjust the dose. And so this patient was put on a standard dose of valacyclovir. He had a history of end-stage renal disease, and he got very delirious. Other medications that are on here are a little bit surprising. If you haven't looked at the list, I really recommend it, because how many of us have treated a urinary tract infection in an older adult, probably in the last week, using one of these antibiotics? So Bactrim, nitrofurantoin, ciprofloxacin, amoxicillin, all of these really should be renally dosed in adults with chronic kidney disease or end-stage renal disease. And I think we forget that, so it's important to have a reminder. Other medications that may surprise you that they're on the list, Xarelto or rivaroxaban, how many patients are on that? Gabapentin, all of these medications need to be used cautiously in people with renal disease and also with people who are on multiple medications. We need to make sure that they're not going to have interactions, because then they could be coming back to the emergency department much sicker with delirium. So the takeaway from this case is that we need to identify delirium in the emergency department. If we can identify the cause and reverse it, we can hopefully alleviate some of the morbidity and mortality from this disease process. And a lot of times medication can cause delirium in patients. And so if the patient is delirious and you're not sure why, maybe start with their medication list to figure out if an interaction or medication that was inappropriately dosed could be causing these changes in mental status. So to wrap up our cases today, we covered COVID-19. We talked about how it disproportionately impacts older adults. It causes increased death and morbidity, and we need to be very cautious when treating these patients. But there are medication options available, and luckily there are vaccines now so people can prevent severe illness. We talked about occult hip fractures. We talked about how MRI is the best test for these. However, if you don't have easy access to an MRI, it's reasonable to start with a CT scan if X-ray is negative. And we need to keep in mind that X-ray can miss up to 40% of fractures in hips, and so we should have a low threshold for obtaining advanced imaging in patients with persistent pain. We talked about ventricular pacemakers and how they cause that left bundle branch block appearance on EKG, which should not prevent us from talking to our cardiologist about the possibility of acute coronary syndrome if the patient has a good story or signs of modified Sgarbossa criteria on the EKG. We talked about how syncope in older adults has an extensive differential diagnosis, but one of the things that sometimes gets missed is aortic stenosis, and this can present with symptoms leading up to the syncopal event like dyspnea, exercise intolerance, angina, new AFib. We reviewed elder abuse. I'm sure you already knew how common it is, but I'm also sure you're aware that we miss it a lot in the emergency department, and that there are tools like screening tools that can help us to diagnose this more regularly and get patients and their caregivers the resources they need to keep them safe and healthy. And then finally, we talked about delirium, which is a life-threatening disease process, sometimes caused by medications, sometimes caused by infections, sometimes caused by another myriad of things, another long differential diagnosis list. But if you can identify the cause, it's often reversible, and you can prevent some morbidity or mortality in your older adults that way. Thank you for having me today. If you have any questions, please email me. This is my email address. I'm happy to engage with anybody about geriatric emergency medicine. It's been my passion since residency, and I'd love to talk more about it.